And it's difficult, of course, to take advantage of a resource if you aren't aware that it exists.
We can't stop at just getting people into the field. We have to help them flourish.
We historically have known that women have been underrepresented in clinical trials. FDA had a guideline in 1973 that recommended that women in their reproductive age should be excluded from phase 1 and phase 2 trials.
Welcome to the ASN Kidney Translation Podcast. I'm your host, Dr. Matthew Sparks, a nephrologist at Duke University, also serving as the communications editor for the ASN portfolio of journals, JASN, Kidney 360, and CJASN. Our mission is to deliver insights from the latest advances in kidney medicine and engage in a meaningful discussion on how these breakthroughs will directly impact patient care. In this episode, we have a special focus on gender equity and the experiences of women in nephrology. We'll be discussing 3 studies that shed light on various aspects of gender disparities within nephrology. First, we'll explore insights from a study published in JASN highlighting the challenges and progress women face in academic nephrology. Next, we'll turn to findings from CJASN with a national survey examining the unique experiences nephrology fellows face when considering or starting a family. Finally, we'll discuss a study published in Kidney 360 revealing critical trends and gaps in gender representation in nephrology randomized clinical trials over the past 2 decades. Join us as we unpack these important studies, discuss their implications, and consider steps needed to achieve greater gender equity in nephrology. Let's get started. Our first guest is Dr. Nisha Bansal, here to discuss a research letter published in JASN titled Perceptions and Experiences of Gender Equity Among Women in Academic Nephrology. Dr. Bansal is the first author on this manuscript. Welcome to ASN Kidney Translation.
Thank you, Dr. Sparks. My name is Nisha Bansal, and I'm a professor in nephrology at the University of Washington in Seattle.
How did this all start? How did this paper come about, and what was the impetus for getting this really important manuscript out?
Thanks for the question. So, I am a woman in academic nephrology and also part of the executive council for the Women in Nephrology Group, which is a national organization that looks to support and advocate for women in our field. We noticed that there was a lot of literature in other specialties, including internal medicine, which described experiences of women in the field, and noticed that there was data lacking in nephrology, which we thought was impeding progress in terms of opportunities for career advancement for women. And so the purpose of this was simply a descriptive analysis to get a feel of the community, feel how women in the academic nephrology are feeling in terms of their support and their resources in their careers.
Before we talk about the findings, let's first talk about the methodology for this paper. What did y'all do to collect the information about the experiences that women were currently having in the field?
So we used a validated survey. It's called the Culture Conducive to Women's Academic Success, or the CCWAS survey, which has been used in other mixed methods evaluations of women in academic medicine. This is a 45-item instrument that queries women on access to career advancement, work-life balance, freedom from gender biases, and support of leadership. For the purpose of this paper, though, we were worried about the length of the survey, which was 45 questions, and so we modified it to be 24 questions. And this was an iterative process done by the co-authors of this paper. We also added 2 open-ended questions, which were, are there any programs or interventions that you would like to see in your division to improve gender equity? And then any other information that the respondents wanted us to hear. And so the survey was distributed to women in academic nephrology, and this included MDs, DOs, and PhDs, and specifically non-trainee. And so we were really focused on attending physicians and scientists. And the survey was distributed through the Women in Nephrology Network, through emails and social medias, as well as personal contacts of the Executive Council with women in the field. We received 115 respondents to the survey.
Can you tell us a little bit about what other disciplines have used the survey similar to this? And are they all in medicine, or was it used in other fields?
So this particular survey, the CCWAS, was used in internal medicine, specifically looking across academic institutions and departments of medicine. Other subspecialties, such as cardiology, oncology, and pulmonary critical care, have used different surveys to evaluate the issues around gender equity in their respective fields.
When I'm thinking about the current issue that we're at here, trying to understand how women can advance in the field and what are the obstacles they face, one is just the numbers of women in academia. And that obviously doesn't tell you the whole story. And this, I think, is digging deeper. So I wanted to just stop here and pause and where are we with the numbers of women in nephrology and also in training?
Great question. So, from a 2017 survey, we know that about 30% of nephrology attendings identify as women. When we look at trainees, the most recent data we have is from a 2023 survey, which found that 39% of nephrology fellows are women. And so the question arises, well, how does this compare to our colleagues in other subspecialties? So, looking across all medical subspecialties, the average is about 40% of fellows in other medical subspecialties are women. So, we're almost at the average that is seen across other medical subspecialties, and we're certainly doing better than some specific subspecialties. For example, cardiology reports that only 18% of their fellows are women.
Great. Now let's move to the survey. So it started out as almost a 40 something question survey, got it down to about 25. It's specifically going to attendings, both clinical and research. And this is international, not just in the United States. Is that correct?
That is correct. It was distributed to women both in the US and across other countries.
115 responses. Can you sort of give us an idea about, one, it's really hard to do a survey in this day and age. What was the feelings of the authorship about the survey response of 115?
Yes, and this is a good question. Surveys are difficult to conduct, and we were definitely worried about survey response, which was our motivation to shortening the survey by almost half, actually, to increase responsiveness. And so I think that when you look at the 115 responses, certainly we would have wanted more, but we felt pretty good about the responses we got in terms of the diversity of the people that were responding. We found a broad distribution across age, across race, ethnicity, years from training completion, women with family, and then types of degrees, including PhDs, MDs, and DOs. We also looked across types of positions that people had, namely whether they're clinician scholars or educators, physician scientists, or scientists. And we had representation across all these various groups. So although our total N was on the smaller side, we felt like it was a pretty diverse group of respondents.
Now, let's just dive into this paper. I think everyone's interested to hear what was found. What are the main findings that you want to get across to our listeners?
Yeah, so as I mentioned, we queried people about 4 dimensions: access to career advancement, work-life balance, freedom from gender biases, and support from leadership. And to get at these themes, we asked a series of questions as well as analyzed the open-ended questions that we had at the end of the survey. And I want to highlight some good things that came out of the responses. For one, positive aspects that women highlighted were that they felt like they had equal access to mentorship and research opportunities compared to male colleagues. They also felt very protected from sexual harassment. And overall, there was a feeling of support from academic leadership. We specifically asked about support from division chiefs or heads. That being said, there were some noted opportunities which were highlighted by women completing the survey, both through the quantitative questions as well as the qualitative comments. A recurrent theme that's not unique to nephrology, I would say, was the need for salary equity as well as transparency. And this seemed like it was an important concern for the women who completed our survey. Additional themes included more supportive family leave policies at their institutions, greater flexibility to accommodate work life, and more action against subtle or unconscious bias.
Those are really important things to discuss. And I wanted to sort of go to one, and that's salary transparency. How does that happen? And what does that look like? Because, as a faculty member in a division right now, I'm struggling to understand what that looks like. And can you describe more about what a division can do to ensure that they have good transparency in salaries?
So I do think that there are certain steps that divisions and institutions can make to ensure salary equity and transparency. First, I think there should be a salary review for all faculty members that are done on a semi-regular basis, which reviews and compares salaries for all individuals that are employed at the institution or within the division and looks across academic rank, years of experience, and scope of work to ensure that there are not disparities. And I think this process is actually best done by somebody external to the division to add a layer of objectivity to the process. I also think that there's a few key points in a faculty member's trajectory where salaries should be openly discussed. First is at the time of initial appointment. We find that many of the salary inequities actually start at that starting point and only are exacerbated as people go through the academic ranks. And then I also think that promotion is a great time to review where an individual is at the time of their promotion in terms of their salary and their overall compensation, and that how it compares with other individuals at the same academic rank.
Yeah, such an important point, and thanks for those really good concrete examples. So, what are some other things that was found that maybe we can move into the work-life balance and the ability to have flexibility, but yet continue in your rank and your career advances? What was discussed about that in the survey?
People have needs for different types of flexibility depending where they are professionally as well as personally. And I think in a lot of ways, the academic medicine model has not evolved with the changing times of what's needed from a contemporary faculty member to, say, raise a family or take care of aging parents or be a supportive partner or have hobbies outside of work that promote their own wellness. And so some of the themes that came out from this specifically, and I can highlight some of the comments that were brought up, is that, for example, division events, whether they be meetings or social events, there was a desire from the survey respondents that these be scheduled during working hours and not off hours to allow more participation, especially for women. There was a need, people also said that they wanted more room for flexible working hours in terms of clinic start and stop times that allow them to drop off their children or pick them up. They wanted specific programs and mentorship around work life balance, specifically about motherhood. And there was a need for recognizing that women have roles outside of being a physician specifically, and many of them felt torn and just felt like the academic model did not have enough flexibility or alternative models of employment that allowed them to fulfill these roles.
One of the big issues that we're facing, not only in academic life as an attending, but also as fellowship, is maternity leave. What was discussed about maternity leave? And I think one of the biggest challenges is one, taking the time off, but two, ensuring that your career trajectory continues at the same pace as someone who's not taking maternity leave. What are some of the concrete things that can be done or potentially done to help with that?
Yeah, this was an issue that was certainly raised in our survey respondents. So, first, I think there has to be transparency about what parental leave looks like at your institution. And it is variable. And I think a lot of faculty do not know what options there are for parental leave, both through the university as well as there might be some state support as well. Additionally, there has to be a recognition that when someone is on parental leave, that there's not the expectation that they're paying back that time, namely clinical work. If there's call weekends and such, and this was a theme that was also brought up in the survey, that there should not be an expectation that women are paying back that time. And so there's that immediate impact of parental leave in terms of your day to day responsibilities. But you've also brought up a bigger point, which is how does this affect your long term career trajectory? And so I know many institutions have what are called stop clocks, where you can pause your academic clock in between promotions, which accounts for the extra time you needed to care for your family, take parental leave, or take any other leave that may be necessary. And so I think this is also a program that's often underutilized and misunderstood by faculty at many institutions. And so I think faculty need better education in terms of what rights they have as employees and how they can still maintain the same level of career progression while not sacrificing what's needed in their personal lives.
What advice do you have for trainees, especially who are women looking for their first job?
Yes. So I think that first job is really important in terms of setting you up on your career trajectory. So, first, I would ask specific questions about the policies that are in place by the institution to support women, whether it's parental leave, flexible work schedules, paths to promotion. These are all really important questions. And as a possible faculty member, you're definitely entitled to ask these questions. Second, I would try to learn about the culture of the division before you join. Understand who makes up the division, what is the style of the leadership, and talk with other women in the division at all academic ranks to understand if and how they feel supported. I think it's really important to have a community that you can lean on, especially when you're starting out. And so, again, meeting others in the division and understanding what is working in that division to promote that sense of community amongst the women and other faculty members is incredibly important.
What are some red flags that a trainee or anyone who's looking for a job should look out for?
I think if you're asking these questions and they won't give you the answers, I think that is a red flag. If you're asking to speak with other women on the faculty, and again, you're not allowed access to those women for some reason, that also isn't a red flag. You want to go into a position knowing that you can ask questions and that there's a sense of transparency where there's an equal exchange of information.
With the data that you have and your group has from this survey, what are the next steps that you think need to happen in order to continue pushing the envelope for equity in nephrology?
Yeah, I think that there was a lot of good things that came out of the survey. Again, this is just a first step. I would say a baby step. We can't stop here. So it did highlight some good things that we're doing as a community, which I'm certainly proud of. There's women felt protected from sexual harassment. There was generally a feeling of support from leadership. I think what the next steps are really partnering with academic institutions in the US and abroad to think about what sort of models would better support women's career trajectory, whether it be salary equity, flexibility, and other types of culture change initiatives that we could take. Think if we pilot these and they're successful in certain places, can we spread the news and spread that experience to other institutions? That would be my goal, is to see some sort of pilot programs that could then be implemented more broadly.
Say, you're an outside consultant for a division chief who's just starting their first job and coming into a new institution. What advice would you have for them, or maybe it's you? What do you do to walk into a situation and right the ship? Like, what are
Yeah.
some first things? Like, here's what we need to do to get this all moving in the right direction.
Well, I think each division probably has its own challenges. So the first is to listen. To really talk with the women faculty to understand what the culture has been, what they perceive as the barriers to their own personal or professional success. And then once you have those data, if some of the themes that came out of our survey does resonate with the faculty at that particular division, I would say that I would advise a division chief to not be constrained by traditional work models. I would think creatively, think about innovative ways that you can support your women faculty. And even the small things can make a big difference. Talking about parental leave in an open manner and normalizing that everyone is entitled to that time off. That can help promote culture change within the division. So I would think there's some small actions that can be taken immediately, and then there's some bigger programs, obviously, that would need greater support from the institution itself. But there's a lot of, I think the first step is really promoting culture change.
So, if you were to take the temperature of nephrology compared to other disciplines of medicine, where are we? Are we doing okay? Are we moving in the right direction? Are we sick and need a lot of work? What's the temperature of nephrology in this really important question for the future of our field?
I think in terms of nephrology, we are making progress. First of all, I'm really delighted to see the increase in number of women fellows that are entering our field. And so that's a first step. We're attracting more women into nephrology. And there's a lot of positive things that came out of the survey, which I want to highlight as well. But in terms of where we can go, we're still not 50-50 in terms of distribution of men and women. And I still think that there are some areas in terms of the culture in academic nephrology that needs some work. But I don't think it's unique to nephrology alone. I think many of our other medical subspecialties are facing the similar challenges, which I think is an opportunity. It's an opportunity for us to band together as medical subspecialties and think about larger, more systematic institutional changes that we could be employing in our own institutions.
So, it's important for all of us to not only talk the talk, but walk the walk and make that nephrology a place that is very attractive for women and all types of individuals to come into. So I think this is a really important, as you said, baby step forward to really get an understanding of what are the issues so that we can start to tackle them. And that's really, I think, most important. If we're going to bring people in, we have to make sure that we bring them into a really comforting and an environment that they can succeed in.
Yeah, the first step is recruitment, and I think we're doing better in that sense. But we also want to retain and help people accelerate and thrive. And so we can't stop at just getting people into the field. We have to help them flourish. And so I think that's where the opportunities lie.
How can individuals listening to this podcast get involved in women in nephrology?
Please sign up. We welcome all people to join Women in Nephrology. It's a wonderful group of individuals who care passionately about supporting others. All you have to do is go onto the Women Nephrology website and sign up. You have access to a series of career development seminars where we talk about these exact issues in a very safe space from experts around the world. We do a lot of networking. We have mentorship programs. So there's a lot of initiatives offered through Women in Nephrology that can help support your career.
Any last things you want to talk about from the survey that we didn't mention?
Yeah, I think we do recognize there are a few limitations in the data that we collected. One is obviously the sample size. So, though we had 115 respondents, this clearly may not be representative of every woman in academic nephrology. And two, we did not collect data from men. So, it'd be interesting to see in a subsequent survey of how perceptions and experiences of men in academic nephrology differ from that of women.
Were there any questions that pertain to LGBTQ that we could learn about their trajectory in the field?
I think that is also an incredibly important area that was not addressed by this survey. We did not collect responses from other gender minorities, including individuals that are non-binary or part of the LGBTQ plus community. So this would be an important step as well.
Thank you very much for coming.
Thank you so much. It's a lot of fun.
The second article in the ASN Kidney Translation podcast will focus on a CJASN original investigation titled A National Survey of Pregnancy and Parenthood Among Nephrology Trainees, a focus on nephrology fellowship. I'm very happy to have the first author, Dr. Gina Dixon, and the senior author, Dr. Jessica Kendrick, join us. Could you both introduce yourself?
Hi, I'm Gina Dixon. I'm a MedPeds Nephrology Fellow at the University of Colorado and currently completing my postdoctoral research years under the mentorship of Dr. Kendrick.
And I'm Dr. Jessica Kendrick. I am a professor of medicine and also the nephrology training program director here at the University of Colorado.
First, let's just frame the question, and it's a really important one. Parenthood happens, and it happens frequently. It's really important that we allow our trainees to have the ability to start a family. Dr. Dixon, you're currently a fellow. Talk about this project and how it started and what it means to you.
So I started working on this project through Women in Nephrology through the Lili Zhao Fellowship. And at the time that I was completing the fellowship, I was actually pregnant with my now 1-year-old. And I was working with Dr. Kendrick as my WIN mentor and also my program director. And so the project just felt very kind of pertinent and timely to get more information about what this journey looks like and what pregnancy and parenthood looks like for our nephrology trainees.
I'd like to hear a little bit more about the fellowship with Women in Nephrology, or WIN.
Absolutely. So the fellowship gives me an opportunity to work with the WIN Executive Committee. So a great kind of leadership and mentorship opportunity through them. And specifically, the goal of the fellowship is to focus on a project that really forwards the mission of women in nephrology. And so this project we felt kind of fit within that mission and then again was timely for me.
One of the things that is challenging about being in the United States is that we don't have very good policies in regards to maternity or paternity leave. Every institution is different, and maybe we're making better strides in academia. I'd like to sort of know from Dr. Kendrick, where are we in the United States with paternal and maternal leave in graduate medical education?
Yeah, so that's a great question. And as you mentioned, what we're seeing is every place is different. So every state has their own laws, their own FMLA leave laws that kind of direct the parental leave that is available. And then each institution has their own set as well. And then I think the other complicating issue that we get to into the paper is the ABIM also has their own set compared to ACGME. So with all of these different policies, it can make it very difficult. So it ultimately comes down to each individual training program and then potentially with their local GME. Hopefully they're following the guidelines of ACGME and ABIM or the surgical subspecialties or whichever board they report to, but it's very complicated. They should get at least 6 weeks of parental leave. and there's ways to get more. Most FMLA will allow up to 12 weeks, but as we've seen with the boards, both ABIM and ACGME, they really say you can have 6 weeks only as a trainee.
What was known about nephrology in particular before this paper came out? Was it just hearsay, or was there any understanding or literature surrounding this topic?
Yeah, I think very little was known. A lot of the studies that were done were across GME or maybe specific to other internal medicine fellowship programs, things like cardiology, gastroenterology. But we really kind of had to piece together the data from different subspecialties. Pediatrics had great lactation data, OBGYN had great outcomes data, and sort of wonder how this looks in a nephrology training population.
Maybe that's a good way to stop here and just sort of what were the main areas that you were focused on outside of, as we've already mentioned, the leave? Like, what are all the big areas that you're trying to understand more information about?
Yeah, so the four big areas that we had were leave, pregnancy accommodation, so things like infection accommodation, being able to attend doctor's appointments, whether or not you receive accommodations for third trimester, for extended work hours, or for night float, lactation accommodations, and then childcare. So those were kind of our four big buckets. And then we also examined what the culture is surrounding pregnancy and parenthood during training. So knowledge of fertility balanced against sort of desire to have a family and what might prevent you from having a family, and how a trainee might put all of that together to make their decisions.
Well, let's talk about the methodology. What methods did you use to actually get the survey out there and answered? And how did you construct all the questions and things like that?
So we looked to pre-existing literature to determine kind of what questions were the most pointed and received the best among different physician trainees. So again, pediatrics had lactation literature, OBGYN had outcomes literature for pregnancies, and then we adapted them to fit a nephrology training subspecialty, and of course expanded them to ask more questions as kind of more literature evolved and wasn't applied to a physician trainee population. Then we distributed this to US nephrology fellows through both program directors and department chairs and asked them to distribute to their respective trainees.
How many trainees answered your survey?
Just over 100 trainees answered the survey.
Was the survey tied to the in-training examination?
No, unfortunately, it was not. We had asked ASN about that, but we had missed the cutoff, so we had to do it separately.
Can you go through the results with us?
Absolutely. So one of the greatest things that we found was just sort of this theme of a lack of awareness. So there was a lack of awareness of national and program-specific leave policies, as well as a lack of awareness of pregnancy accommodation policies, lactation resources, and childcare resources available at each individual institution. And so this is something that we found across all of the U.S. nephrology fellows. And then beyond that, we explored sort of knowledge of fertility and desire to start a family. We found that a large proportion of respondents indicated that they were interested in having a family, but that they would want to defer starting a family or having a pregnancy or pursuing parenthood during training. And so we asked why that would be. And so in a lot of cases, there was this perception that the fertile window is longer than it actually is, that we are fertile to a greater age than is actually the case. And then beyond that, trainees reported that they had concern for having to extend their fellowship. And so that was another reason that they would choose to defer pregnancy or parenthood.
As a program director, as one of the things was just unawareness of the policies, what are some concrete examples on how we can make that happen? How can we make more trainees aware of said policies?
This is something that we actually have been discussing, and we brought this to the forefront when Gina was expecting and we were going through everything. And so really what program directors can do is just make this part of your onboarding process. Show them where the information is, because fellows may not just come out right and tell you, oh, I'm thinking about having a family, I would like to know what the leave policies are. So if you give them a printed handbook or an online handbook, if you can put this onto your website where it's just resources available, they would, have that. We also have discussed with GME, including this in their onboarding of, every place does a little bit different. So onboarding of fellows might be different with the actual GME from the institution, but our GME is now trying to include this information as well. So I think program directors have a couple of different things, but we were very surprised when like over 60% had no idea of their GME, institution policies, and over 40% had no idea about their training program, what their parental policies were.
Were individuals who had declared an interest in starting a family more aware of these policies?
We didn't stratify for kind of whether or not they were interested in having children, but we did stratify for whether or not they had children. And again, our N is 120, so it's sort of hard to find like a strong association, but we did show that just across the board, there was a lack of awareness.
More of the women were aware of parental policies than the men. Again, didn't reach statistical significance, but we did find that.
Let's move on to the second bucket of lactation accommodations, which personally for me, having several women who have been pregnant over the last several years in our program, it's something that I've been working on ensuring that information is out there. And it seems like there's also been a big push from local GME offices to do this as well. And this has only been over the last 4 or 5 years. So tell us about what was found in that bucket of lactation accommodation.
Yeah, so I think this is one of the areas where we were surprised because we did find that only 47% reported their program provided breaks to express breast milk. An additional 43% were just unsure about whether or not this was provided. And I think that really just speaks to the theme of the paper, which is just this lack of awareness. And it's difficult, of course, to take advantage of a resource if you aren't aware that it exists.
I wonder if this survey was done 10 years ago, what we would find. Dr. Kendrick, what do you think?
I think it would actually be a lot, even more obvious that they had no idea about policies because we weren't talking about these things 10 years ago. I think we didn't have as many women in nephrology. And then of the ones who did, you kind of figured it out on your own. I was in that era. It's been a little bit more than 10 years now since I was a fellow. But, when we had pregnancies, it was just sort of figure it out on your own. And you did, and your program director was helpful, but there was definitely not resources or things available. And there was definitely not lactation rooms that we could utilize.
This is really important because oftentimes really challenging for a nephrology division to be able to accommodate for those sorts of things because they need a GME in the hospital. And it is really refreshing to see that this is a topic that is coming up, but it has only been in the last 4 or 5 years, sadly enough. And so hopefully that's reflecting a little bit. You're sort of seeing the lactation accommodation. The numbers are, although they're still not great, they're a little bit better than the parental leave policies, for instance. So it does show that we are making some progress, but we still have a long way to go.
I think that's definitely true. I think hospitals have been better about providing rooms. They're not always convenient for fellows, and that's what we have found is they're not conveniently located potentially, so you might have to come up with some other things. But at least this is more on the radar of programs as well as hospital systems.
Okay, let's move to the next bucket. I think for me personally, we have twins, and it was really hard to find childcare as an attending. So I can't imagine as a trainee coming into a new institution in a new city. What did you find in this really challenging bucket of childcare accommodations?
Yeah, so we found that most trainees do not have access to on-site childcare. And I think that's really important to know because the AMA did recently release a policy encouraging institutions to have on-site subsidized childcare for trainees. Just knowing that trainees work extended hours, work odd hours, and having accommodating childcare is such a huge piece of that puzzle. And if institutions did have some form of on-site childcare, or emergency or on-call childcare, those trainees still likely weren't aware of it because, again, we found this lack of awareness of the childcare resources that are available. But beyond that, we found that it's less likely that there was a large proportion that have the on-site subsidized childcare.
Another really hard area for a nephrology division to tackle. I've seen the GME office push for this more often, but it seems like it's just childcare in of itself is hard to access for anybody. Dr. Kendrick, how can we solve this really, really hard topic about childcare?
Yeah, I mean, this is really tough because if the institution doesn't have a relationship with, a childcare facility that would offer subsidized care, that's difficult. I think, some things that at least programs can do, like as you're a single program director, you're probably not going to make change. But if you can go to your GME, you can rally up the other program directors. This is something you can really push for with your institution and see if that can be at least somehow get them access to maybe lower cost childcare. The other option that's out there is offering sick childcare. And so I know a lot of departments of medicine, ours does it here at the University of Colorado, is they will provide sick child care. So for fellows and residents, as well as attendings, if you have a sick child, they have this, dedicated sort of nanny vetted service that you can call upon. So that way you don't have to miss, whatever you have work duties that day. But again, that requires resources and buy-in from your department, your division, but it's something that nephrology divisions could do if they have the resources available.
I think there's one other area I wanted to sort of talk about, and that's pregnancy accommodations, especially leading up to delivery. How did that fare among the nephrology fellows so that they, weren't doing 30-hour calls or traveling long distances in the hospital over and over again?
Yeah, so I think that this topic is pertinent and timely. We have seen that some training programs, some internal medicine and emergency medicine programs, have adopted policies that preclude pregnant trainees from working overnight shifts or call shifts during pregnancy, particularly during that third trimester. And that's largely because there is some OB data that shows that women who work rotating shifts, fixed night shifts, or more than 40 hours per week have an increased risk of adverse pregnancy outcomes. And so when we asked nephrology fellow respondents about this, largely they were unaware of pregnancy accommodations that their institution had, and only a small proportion reported that, yes, if they were pregnant and it was a third trimester pregnancy, they would receive accommodations during night float and call shifts.
This is great news that we're making progress. We still have a lot of work to do, but the elephant in the room is when you leave. Is there efforts to study, especially private practice, and these same issues? Because as fellows leave, they are now starting to recognize that many private groups have no policy. It's very uncomfortable to ask because they're trying to get a job. And in academia, you've got the policy there. You can just see it. It's a little bit more transparent. What's the future of understanding private practice, all of the childcare issues that we're talking about today?
I think that's a great question. And, I don't think we have the answer. I think it's definitely something that needs to be looked into. I know Wynn was trying to do surveys of, women in nephrology out there, asking them about parental policies, especially in private practice, to try to see if we can get any information on how this is. I think we are starting to see improvements with the state laws now that are in effect for a lot of FMLA leave and paid FMLA leave. So a lot of, that is now required. So I think that's going to help people in private practice, whether they're men or women that want to be able to take parental leave, because it's going to be required. So private practices are going to have to adapt. How they do that, again, is going to probably be very specific to the practice and how many partners and what state they're in.
Yeah, it's really hard to gather data for that group. And it is really important as we bring more women into the field, or anybody that wants to have a family. Moving in past fellowship is still a very important aspect. Any final comments from either of you about this topic that you want to leave to our listeners?
I think one thing that we just love to highlight is that we did see that of the 40 fellows who chose to pursue pregnancy or parenthood during medical training, 75% of them didn't change their career plans. And I think that piece is just a really nice kind of highlight to end on, to share that those who do choose to pursue pregnancy or parenthood are still quite successful.
That's great to hear that.
When we looked at reasons that fellows might defer having a child during training, it was really because they were concerned they would have to extend their training. Over 60% said that, and they don't want to extend training, as we know this can have adverse things for jobs if they can't start right away. So I think, again, having those conversations with their program director, because there are accommodations that can be made. You don't always have to extend training. And just, again, so we want to make sure that we are getting awareness of policies, and that as program directors, we're available to have these conversations with fellows so that they're not deferring having a child just because of accommodations and having to potentially extend training.
Thank you both so much for joining us on the ASN Kidney Translation podcast, and also congratulations to your paper. I sincerely hope that what you've shown to the community will help improve the fellows' experiences, and most importantly, to be able to start a family, which is a very important aspect of a lot of individuals that are in the field. So thank you both so much. I look forward to seeing your next paper on these topics like this.
Thank you.
Thank you.
We welcome Dr. Candiel Sumro, who is an assistant professor from NYU. She is the first author of a paper published in Kidney 360 titled Gender Disparities in Nephrology Trials, a meta-analysis of enrollment trends between 2000 and 2021. Welcome to ASN Kidney Translation.
Thank you for having me. I'm excited to talk about our publication.
Well, first, I want to hear about how this project got started.
I think the idea initially came from my mentor, and we are both interested in clinical trials as researchers, and we wanted to really look at the trends of enrollment, initially in terms of race and ethnicity, and then as well as gender in nephrology clinical trials, because that had not been done before.
Curious, has this been done in other fields?
Yes, several papers have been published in cardiology, in cancer research, as well as neurology that have shown similar trends, and that prompted us to look into nephrology trials as well.
Well, obviously, an idea is an idea. How did you take it from an idea and actually start this project?
So first, we assembled a team, including research coordinators, fellows who were interested in participating. We also met with a medical librarian at NYU who helped us create a search term list that which we used, and then we followed the PRISMA guidelines. We created a protocol that was registered at Prospero and started to screen papers to include in our final cohort.
It seems like a very daunting task. You look from papers from 2000 to 2021. That's a lot of papers. How do you go through all of those papers to pull out all that information that you need?
We thought it was necessary to be as comprehensive as possible, and looking at it over this period of time would allow us to really see the trends. So in order to do it, and we had to write the protocols and be as systematic as possible.
Are there any tricks or tools to scan this many journal articles and actually get the data that you need quickly?
Yes, we found this software called Covidence very helpful. The medical librarian can upload all these individual publications and trials into that software, and then it becomes easier for the team members to go through them and scan. You can also do the initial scans, which are abstract, on your phone. So there's an app.
Oh, wow. So you can actually do this like sitting on your couch.
Yes.
How long did it take to go through all the papers, and how many did you initially go through?
We initially uploaded over 4,000 applications, and the overall process took us months, and just to be thorough. And then we finally had the final cohort. So the most time was spent really going through the studies and making sure we're including the ones that really need to be included.
Now, when you say they're high impact trials, what is the definition of that?
We define them as trials that led to like practice changing, in terms of whether there was how we treat patients with kidney disease, or policy changes in terms of like they change the standard of care.
That seems like a fairly subjective criteria. Did y'all have objective criteria surrounding that?
Yeah, so we wanted to include trials that had hard outcomes in terms of mortality or need for dialysis.
And out of those 4,000 papers, how many did you get down to in your final number of patients that you would analyze for how many women were enrolled in the trials?
So the final cohort included 380 randomized controlled trials, and out of those, 98% reported gender distribution.
So there are a few trials that don't even report to the gender distribution at all.
Correct. I was surprised by that.
The NIH had a mandate about the inclusion of women in randomized clinical trials. When did that come out?
So initially, I think we historically have known that women have been underrepresented in clinical trials. And it started initially after the thalidomide aftermath. FDA had a guideline in 1973 that recommended that women in their reproductive age should be excluded from phase 1 and phase 2 trials. And I think that sort of spread more broadly into leading to under enrollment of women across the ages. In 1977, the NIH came out with more guidance and recommended that women be enrolled in trials regardless of their reproductive status or the use of contraceptive pills.
Can you tell us a little bit about what the thalidomide issue was?
So it was a drug that was commonly used by pregnant women for morning sickness. And later it found out it led to congenital heart defects and birth defects. So that after that, it led to a guidance change from the FDA.
So that really diminished the number of women that were participating in trials after that?
Yes, and that persisted for decades, which led to a lot of what we think in information loss in terms of how CKD or chronic kidney disease is different and presents differently and has a different prognosis in women compared to men.
Tell us, what were the results that you found out of these 380 randomized clinical trials? How is nephrology doing in our enrollment of women?
We found that there was an imbalance in the enrollment. Male participants accounted for 62% of the total participants, and female participants accounted for 38% overall.
When I looked at the whole numbers, it's almost, 250,000 men, and then maybe almost 100,000 less women. That's a considerable number and a big disparity.
Yes, and we further broke it down and we looked at the trend over the last 20 years, and the trend with the male predominance continued throughout the 20 years.
Well, that was very surprising. You would expect to see some improvement over time, and that just really, I think, goes to show we have a long way to go. A lot of education to do for our research infrastructure and for the public in general to improve this. Now, what does it look like in specific disease trials like AKI, CKD, glomerulonephritis? Do you see any differences there?
For most parts, the results were consistent again. It showed that male participants were predominantly enrolled in all categories of the trials that we studied, including AKI, transplantation, CKD, and dialysis, with the exception of glomerulonephritis trials, where women were marginally included at a higher rate.
And so, how much does that take into account the prevalence of some of these glomerulonephritis, especially lupus in women?
I think the results reflect the prevalence of the disease. For example, most of the trials that skewed this result were lupus nephritis trials, which we know is highly prevalent in women. And the second category was IgA trials conducted in Asia, where women tend to have a higher prevalence of IgA nephropathy.
Now, how do these trends look in different parts of the world?
So globally, the enrollment results show that male participants were enrolled around 62%. And this trend was consistent throughout international trials, European trials, and Asian trials. In the US, they were just about below 60.
One of the questions I had about the US proportion is the VA. As we know, the VA has a very large proportion of male in the VA system. Did that play into this at all in the United States cohort?
It is possible. We did include trials that were conducted at the VA, but I think given the overall results and the consistency of results in different analyses, we believe that it was maybe not a big contributing factor.
Any other things about the study that you wanted to mention?
I think I was most surprised by the CKD results because we know that CKD is more prevalent in women, but the progression to kidney disease and mortality are higher in men. And there isn't a lot of convincing data to describe or explain this phenomenon. And I think that enrollment of women in CKD trials that reflects the prevalence of the disease would help explain these differences.
Was there any mention of a non binary gender in any of these studies?
So that's a good question. And we did not find any mention of non binary categorization of sex in table 1.
Is that something that is to be included in randomized control trials in the foreseeable future?
I think so. I think this type of granular data would be helpful. We know that there are differences in prognosis of kidney disease, even in transgender patients and with kidney disease.
Now that we identified the problem, you've putting it out there for the world to see. The important step is now to change this. So, what are some ways that this can be changed? And maybe when answering that question, you can also sort of postulate on why this is the case.
So I think the policies that were made decades ago, we are still seeing the effects of those. So moving forward, I think for policymakers, it is important for them to consider expanding their policies to further enhance and facilitate enrollment of women in trials. In addition, I think diversity of the investigators and the staff, even research coordinators who are really approaching these patients for enrollment in clinical trials would be helpful. In addition to that, a stratified randomization by gender or sex is going to allow adequate representation of women in clinical trials. And pre-specified subgroup analyses based on gender are also recommended to be included in every clinical trial results.
What are some of the next steps that you and your group have on this topic?
I think in the future, when journals accept publications and trials, they should mandate reporting of the gender and a non-binary categorization, as well as pre-specified subgroup analysis based on gender is mandatory for publication.
One of the questions I had is there any information about whether or not the genders were self-identified or were categorized based on what maybe the research staff would mark?
So this information was not available for gender. For race and ethnicity, a lot of publications do report whether the race was self-identified, but that was not the case for gender categorization.
Basically, is it unusual or just not done?
I don't think it's done.
Is that something that should be done as well?
Yes, I think that it would help the readers and the consumers of that research to really apply it to their patients and be able to make extrapolation of the results in practice.
Thank you so much for taking time to talk about your paper. Congratulations. And I'm really hopeful that we're going to see some really positive changes in the future on enrolling women into randomized clinical trials.
Thank you for having me.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.